Good morning, everybody. So today the topic is cognitive assessment in older adults. I would like to thank Ceylon College of Physicians as well as Sri Lankan Association of Geriatric Medicine for giving me this opportunity to do this presentation. As you all know, the cognitive assessment is paramount important in older adults, especially when there is a concern of their cognition. So we all know Sri Lanka has one of the fastest aging population in Southeast Asia. Currently, our population, 13 to 14% of our population is aged more than 60. So by 2050, 1/4 of us will be more than 60. So therefore, as physicians who are looking after, as doctors who are looking after this wide cohort of geriatric population, it's important to know their main geriatric problems, as well as how to do at least a brief assessment of them. We all know the cognitive impairment is one of the geriatric giants that we encounter when we see geriatric patients, people who are more than age 60 to 65 years. So therefore, I feel today's lecture will be important for the audience when they do their practice, especially when they are in the outpatient clinic, when they are in the ward, when they are in a rushed emergency department, to do how they can manage their time and do a cognitive assessment of these elderly patients. So during next 20 to 25 minutes, I will my outline of my lecture is like this: introduction, use of cognitive assessment, and tools used to test cognitive impairment, distinguishing causes of cognitive impairment, and qualitative assessment, little briefing about the qualitative assessment, and integrated care for older people, ICOP, which is introduced from WHO regional office, and we were trained as master trainers to train primary care physicians to identify the geriatric problems, especially this cognitive impairment, and conclusions. So we all know the cognitive assessment is useful to test for cognitive impairment. Main three areas we concern is the deficiency of their knowledge, thought process, and judgment. So we concentrate these three areas when we do a coherent cognitive assessment. So aging and cognition will have very close relationship. We all know that. Three wide categories of cognition is there. Three wide categories are there in their cognition. First and foremost is the physiological aging and physiological changes in their cognition. This cognitive aging does not fit into any of the categories of cognitive impairment or dementia. But remember that we need to deal with this problem when our patient cohort is getting wider. And second thing is the cognitive impairment, not dementia. If the people do have cognitive impairment, but we are not able to categorize them as dementia because they are not compatible to the scores and cutoff values of our tools. And third category is the dementia. You will understand the burden of dementia when the population is aging, when we are aging. At the age of when it comes to the 65 years of age, so it is less than 1% the prevalence of dementia, but more than 65, it goes to nearly 11%. When aging advances, when it is more than 85 years of age, 1/3 of them will have dementia. So you can understand the importance of the assessment and diagnosis of dementia when we need to make a shared care plan for their further management when the age advances. And cognitive impairment, not dementia, will carry 17% of prevalence when people age more than 65 years of age. So the use of cognitive assessment, that also we need to understand. So we do screening for cognitive impairment. Especially, we do not do cognitive assessment of each and every patient because it is time consuming, it is costly, as well as it needs a specialized manpower. So then the screening, we do cognitive impairment when there is when they raise a concern, either patient or the caregiver or the relative, when they raise a concern that this patient, this patient does have some sort of cognitive problem, then we do screening. Then we assess, when we do a cognitive assessment to differentiate the diagnosis of course. Once we diagnose dementia, we need at some point we have to differentiate which diagnostic category this dementia fit into, like Lewy dementia or the frontotemporal dementia. It is little advanced. Then the third category is rating the severity of disorder or monitoring the disease progression. That is when we do the review, either in the clinic or in the ward, when we do reviews after diagnosis, then we do cognitive assessment. These are the three areas where clinicians do their cognitive assessment. As I said earlier, this is time consuming and it is costly. So therefore, we need to understand what is the importance of cognitive impairment, what is the why we do this cognitive assessment, the purpose and the time which is available to assess this patient. So time, the purpose of the cognitive assessment both carry a important task, important thing. So then only we select which instrument, which tool we use to assess the cognition. These are the commonly we use even in our country and when we were doing our overseas training. So these are the main cognitive screening tools we use. Mini-mental state examination from medical school days, we are familiar to that MMSC, and the Montreal cognitive assessment. It is advanced than MMSC, which Montreal cognitive or the MOCA assesses many categories, many components of the cognition compared to MMSC. So then the abbreviated mental test, AMT is the one is rather simple test which we use in acute medical take to assess the delirium, acute confusional status of elderly people who does have fluctuating course of their confusion. So then clock drawing test. Clock drawing test is also widely used cognitive screening tool where we give the task of drawing a clock to the patient. And then the mini-COG, that is an extended version of clock drawing test, where we assess orientation in addition to the clock drawing test. Then there is some extended versions of MMSC. Once we screen the person, once we detect the dementia, so we use some extended versions of MMSC like Edenbrook's cognitive examination kind of test. Those are very time consuming, but which assesses many of the cognitive components of the patient. So having said that, we need to understand the limitations of the cognitive assessment also. So it will be very harder to establish the presence of establish the accurate score when there is illiteracy, dysphasia, sensory loss, and in people who do not speak English as a first language. If they do not have much fluency in the English, so it will be difficult because some of the tests are not validated to the local languages. So they are in their original language. So therefore, these limitations are there. However, we have enough resources which are validated to local languages to assess the cognition. This is the mini-mental test score. So we know that it is very familiar test. We assess major six components of our cognition. That is orientation, registration, attention and calculation, recall, language, and cognition. These are the six major areas. I'm not going to do the detail. I'm not going to detail these areas. That we assess six areas in later part of my presentation. I will compare the advantages and disadvantages of these commonly used screening tools. You can understand we give 30 marks in MMSC. So the cutoff, widely used cutoff is 23. If it is if you score 23 or less than 23, you have cognitive impairment. But in the authorities have a debate. Authorities have come to a consensus that if somebody has higher educational level like university education and all, the cutoff should be little higher than 23. So some people say it is 25 for the very educated people. If they score less than 25 or less than 25, so we have to refer further for further advanced cognitive assessment. Then we know with advancement of the age, their cognition declines, physiological decline is there. Therefore, very older people, we take cutoff as 20. So 23 is not a hard and fast rule, so that we have to adjust according to their intellectuality and their age. However, 23 is the widely used cutoff in MMSE. Yes, and in addition to that, we have to understand, as it is commonly used one, the MMSE has ceiling and floor effect. That what you mean by ceiling and floor effect is that if you score 30 out of 30, that doesn't mean that you do not have cognitive impairment, because it does not assess some of the component of the cognition. So people will have some cognitive impairment, but it is not assessed by MMSE, and they ceiling effect. Flow effect means that even you score 0 out of 30, that doesn't mean that your cognition is 0. So they have some cognition, because again, it does not assess some of the components of the cognition. So having said that, the next and little advanced than the MMSE is the Montreal Cognitive Assessment. Shortly we say it as MOCA. The MOCA is you can it assesses 8 components of the cognition. So you can see it is 8 components. So visual, spatial, and executive functions. You join numbers and letters, correlate to each other, and then you draw a cube, which is a little complex with some interlocking, and then you draw a clock, and then you name 3 animals. And memory, we check their memory, and attention, language, abstract, and delayed recall, orientation. You can understand we check their intellectuality and executive function, as well as abstract thinking in Montreal Cognitive Assessment. So once we screen by using a brief test, then this Montreal Cognitive Assessment, MOCA, is a good screening, good assessment tool to categorize and categorize their cognitive impairment. So there are 8 components widely used as an advanced cognitive assessment method. So mainly the executive function and the abstract thinking process is assessed in Montreal Cognitive Assessment. So the MOCA covers more domains than MMSE, as I said, and it has greater sensitivity and specificity. So this is the abbreviated mental test score, the third screening tool that I am going to discuss. We ask 10 very simple questions from the patient. Especially we use this AMT, abbreviated mental test, in an acute medical ward to determine, to understand the acute cognitive impairment, especially delirium, in elderly patients. We ask 10 questions, very simple questions: age in years, time of the day, name of the hospital at the moment patient is in, memorize an address. We give very simple address to the patient, and recognizing 2 people, like a doctor and the nurse, if the patient can recognize the person, and the current year, the 2021 is the current year, name of the state head, and that is the current memory, and the date of birth of the patient, and the memorable date of the popular, the memorable day, the Independent Day, or the World War II starting day. So like that, and count down 20 to 1. That is the attention that we check. And then we ask the patient to recall the address that we given at the stage of 4. And number 4, we gave an address. We ask the patient to recall the address at the last point. So we give 10 marks to these 10 questions, 10 points. If it is 8 or less than 8, we take it as that patient has cognitive impairment. So it is the assessment of the delirium mainly we use, and we use this screening tool to review the patient. Once you diagnose delirium by doing other tests and the AMT, and the following day to see whether our treatment and our management plan is making the patient's improvement. So we assess the AMT, and it is very rewarding. They score more points in AMT in the review visit. So screening and review purposes, we use AMT. So it approximately takes only 3 minutes, but MMSE takes like 8 minutes. Montreal cognitive screening usually takes 15 to 20 minutes. So this is very brief test AMT. So AMT takes 3 minutes, but the researchers have validated this AMT into AMT4. Out of those 10 questions, we extract four very validated questions to screen in a rush emergency ward round, emergency department ward round to detect delirium. We ask the patient's age, date of birth, and the place where at the moment, and the year, current year. So if they can answer these four questions fluently, so it is very unlikely that patient, less likely that patient got cognitive impairment in this visit. So then, even if they can't answer one, so that means that the patient has some cognitive impairment. Then we refer the patient for the further assessment. So this is the fourth test and the very simple test and widely used. Even our trainees use this test to assess their patients' cognitive cognition. So the clock drawing test. Clock drawing test is very simple. It doesn't the patient's ethnicity, intellectuality, and all these things are not affect. All these things not affect this test. So we just ask patient to draw a clock. So draw a cycle and put numbers as it is in a clock face. And you ask put on the hands of a specific time. The time usually we give is 10 past 11. So then if patient can do the cycle correctly, draw the cycle correctly, put numbers correctly, and put hands on the clock face correctly of the specific time, then we give 3 marks. So each point we give 3 marks. This is the clock drawing test. So you can understand here we detect their intellectual function, visuospatial and visuospatial ability of the cognition. So and constructional practices. Visuospatial, constructional practice, and frontal executive functions we assess in clock drawing test. It's a very brief test, but very useful test. So then we give 3 marks. So to say that patient is not less likely to have a cognitive impairment, they should score 3 out of 3. So it is independent of, as I said, intellectuality, the language they speak, and cultural ethnic factors. So clock is very familiar to each and every nation. So these are the clocks drawn by different stages of Alzheimer's. One is mild, second is moderate, third is severe Alzheimer's disease. So it's very important test. Then the little extended version of clock drawing, that is mini-cog. In addition to what I have explained in the clock drawing test, we give 3 names, 3 unrelated names at the beginning of the test. We give 3 unrelated names like price, dough, and pen. Those are unrelated, different 3 names. And we ask the patient to remember these 3 names, and then we give the task of drawing the clock, like clock drawing. Once the clock drawing is finished, then we ask the recall 3 names that we have given before. So we give again 6 points there. So patient needs to score 3 or more to say that they do have less. They are having less they do not have cognitive impairment. It should be either 3 or more than 3. It is brief and minimum language and educational ethnic bias. So mini-cog. It is in a geriatric clinic, in a cognitive assessment of cognition. If we usually combine mini-cog with MMSE. So it both will carry more sensitivity than specificity one alone. So this is a brief comparing brief assessment scales. You can see. So the MMSE assesses 5 components, and there it takes 8 minutes. Mini-cog assesses that is mini-cog is the clock drawing and the recall test, which assesses 5 components. So it is just 3 minutes. So mini-cog has a good sensitivity according to this, and the resources is pen and paper only. So then this is the last one I just wanted to compare with these brief tests. This is Addenbrooke cognitive examination. It assesses many steps, many areas of cognition, and it takes 20 minutes, and it needs specialized people and many resources. So this is what I have explained so far. It is when somebody is having cognitive impairment, you can understand. So it takes me much time, more than expected time that we have to understand. So as we are dealing with many pediatric patients, we need to have patience with the patient when we are assessing the cognition. AMT is mainly for the delirium assessment. Clock drawing test correlates with the MMSC, but the sensitivity and specificity to detect dementia appears to be little lower than MMSC. That we can understand. MMSC is detailed in 6 areas, and clock drawing test does have some capacity to detect the frontal executive cognitive abnormalities in people with who score normal. Normal MMSC people with normal MMSC will carry less marks in clock drawing test because it detects executive cognitive abnormality. And then the other thing is that we use cognitive assessment tools to distinguish causes of impairment. Here, I should stress that it is just not a tool or a scale or a score. It is just comprehensive geriatric assessment. It should be comprehensive assessment of their cognition. We need to take a good history. As patient is cognitively impaired, it should be the relative caregiver or the closest family member. Then the thorough physical examination to detect any hidden signs like Parkinson's. If somebody is having cognitive impairment and Parkinson's, you know, it pointing towards Lewy body dementia or Parkinson with dementia. So then the history will be important to differentiate, and some investigations to detect alternatives as well as potentially reversible causes. Like we do vasculitic screening, vitamin B12, hemoglobin, TSH to detect hypothyroidism, and imaging to see if there is space occupying lesion, hydrocephalus or subdural hematoma. So these things also dementia mimickers. And then the distinguishing causes of impairment. So we use after doing these comprehensive initial assessment, then we use assessment batteries. So depression will be dealt by Dr. Kapil Ranasinghe. We should not forget depression. It is one of the major areas of cognitive impairment. So geriatric depression score is the one we use in our clinic. So then the delirium, we use cognitive confusion assessment method, CAM, where we assess 4 areas. Dr. Shahandi Silla will be discussing with this. And then the dementia, where we assess, where we do informant question. These are advanced things. Informant questionnaires, frontal subcortical assessment battery, extended versions of MMSC, I discussed few times. And we combine clock drawing test and MMSC or Addenbroke's cognitive examination. I'm not going to be in detail of these things, but we need to know these tests are available. When necessary, we have to refer them and we have to assess our patient accordingly. And then some qualitative assessments are there. In addition to those scales, we assess attention by reciting reverse sequences, and list the month of the year backwards. We assess attention in those methods, and memory, of course, episodic, semantic, and procedural, and working memory we assess in different ways. So language, dysarthria, comprehension, paraphrasia, we assess separately if we have any concern about those areas, and visuospatial skills, and we ask copying the diagrams like interlocking pentagons, MMSC, we do that. So these are the qualitative assessment methods. And frontal executive function, planning, abstract thought, judgment, we assess by different ways. So that I just want to tell these things are these things also we need to use to assess their isolated areas of cognition. So asking the patient to interpret proverb can assess abstract thought. That in our clinic we use that. We just ask proverb and we ask them to interpret the proverb. Finally, the integrated care of older people, ICOPE, that is the WHO collaborated program where we were trained as master trainers to screen geriatric people of their major cognitive problems, geriatric giants, cognitive impairment, incontinence, instability, falls, mobility, and polypharmacy. All these major geriatric problems are being assessed by ICOP assessment methods. Where the cognitive assessment also dealt there. So first we ask whether you have in the ICOP assessment, in our ICOP clinics, integrated care of older people clinics. First, when we encounter an older people, we ask whether you have any concern about your cognition, or their relation. We ask whether you have any concern about your cognition. Then if they say yes, of course, then we direct them to the advanced assessment of their cognition, cognitive capacity. If they say no, we just ignore the patient. We can't just ignore the patient. We just ask 3 questions. And that is very simple, like AMT4. Remember, we ask the patient to remember unrelated 3 words like pros, price, and do. And then we ask the patient's orientation, 2 questions. Where do you now at the moment, and what is the complete date today? Today is the 2nd December 2021, Thursday. That we need the complete answer. Where do you now? I'm at New District General Hospital, Mater. So we need to have a complete answer. Once we ask 2 orientation questions, then we ask to recall the 3 names that we have given at the beginning. So if they can't complete this test, then of course they have some cognitive impairment. That part also they direct to the advanced assessment of their cognition. So that's how, as primary care physicians, the GPs and other primary care physicians are trained to collect and screen geriatric patients who do have cognitive assessment. So that is the last of my presentation. Then I will draw these conclusions. Screening tests are available that is the presence of cognitive impairment. I have discussed many. There are many thousands of validated tools, but I could not discuss everything. And brief tests with reasonable sensitivity and specificity are Minicog. Minicog is a good test, as I discussed. And typically, shorter tests do not assess frontal executive functions, but brief tests are important for the screening purposes. And the best method of classifying causes of cognitive impairment remains comprehensive clinical evaluation, history, examination, and investigations, then cognitive assessment tools. The most suitable technique for a given situation will be judged by the time available and diagnostic accuracy required. And the purpose and the time will come first before you decide which assessment tool that I'm going to use. And be familiar with the advantages as well as disadvantages of the various techniques. And all doctors who treat older people should be able to administer a short cognitive screening test, at least AMT4 to assess and screen for the cognitive impairment in older adults. That will be the end of my presentation. I would like to thank you all again for the patient listening.